Welcome to this home wound care podcast. My name is Mark Coombe, and hopefully you've just seen the presentation, which was a general presentation on antimicrobial resistance. But what we wanted to do was follow that up with some discussion specifically for wound care itself. So I'm absolutely delighted to have back Sylvie Hampton, who's our legendary tissue viability nurse. She was almost one of the first tissue viability nurses in the world ever. And I'm just interested to sort of talk through some of the issues. And so, Sylvie, welcome. Thank you once again for coming. Talk to me over your career about your awareness of antimicrobial resistance and how perhaps your views have changed.
My views have changed a great deal. I qualified in about 1991, and in 1992 my hospital became very aware of MRSA and asked me to open a wound ward that was specifically for MRSA. And so I had a great deal of input into it in the first place, and how terrifying it was at that time to a hospital. Over the time, I now realise that MRSA is more frightening to a hospital or to a nursing home than it is to the individual. So if the individual is well and is carrying MRSA, it's not going to make a great deal of difference to them. But if they pass that MRSA on to somebody who is physically ill, it could actually cause death. So, my way of looking at it is completely different. This is an ordinary Staph aureus which has become resistant. We have got to protect the vulnerable people, and we can certainly avoid it in our normal patients with good care and with making sure that we don't overdo antibacterials. We have also in the future got to be careful with antimicrobials such as silver and so on, because we could become resistant to those as well.
So I'm interested perhaps to come back later to talk about alternatives to antibiotics. But one of the key things that we've discussed in the past was infection versus colonization. Talk to me about that, because I'm not completely sure I know where I am with that.
Right, it's a very difficult one, because when people see redness around a wound, they're automatically thinking that they've got a clinical infection. Colonization is where the bacteria sits on the surface of the wound and it makes lots of changes. It causes a smell, it causes a discoloured discharge, which is different for each bacteria. For instance, Pseudomonas we know is bright green, and Staph aureus is probably sort of a reddy brown. So we do know that sitting on the surface of the wound, it will reproduce. And we know that the bacteria can double every 20 minutes, which is quite terrifying. Wow. When you think about it. But colonization, it's sitting on the surface of the wound. If you take a swab, it will come back as positive. And you will find that antibiotics will be given for what's on the surface of the wound. But clinical infection is actually in the host, making a difference inside the host. And taking a swab off the surface of the wound is not telling you what's going on inside.
My sort of mantra of, if we're not sure, swab it, is completely wrong.
Yes.
And so we shouldn't be swabbing these wounds unless they have a clinical infection.
Yeah, it's absolutely right. I think we're wasting a lot of money doing that, because it is so simple to see whether we've got a clinical infection or whether we've got a colonization. Now, a clinical infection, the person will be having a redness that is spreading, and you draw a black line around that redness, and if it spreads beyond that in 24 hours, it's most certainly a clinical infection. But if it stays within that line, it's very unlikely to be that. If it's a straight demarcation line that's around the wound, that's the shape of the dressing, that is where you're sensitive to the wound fluid. And we have something in the wound fluid called proteolytic enzymes, which is due to the bacteria and so on. And that burns the skin. It's an enzyme, burns the skin. And it tends to stay within the dressing and gives you the shape of the dressing. And then we've got dermatitis, which again generally is an absolute demarcation line, probably underneath the knee and over the toe.
I mean, interestingly, so what you're mentioning cats, but what you're sort of saying is that the where it's demarcated with the wound, that's actually a contact dermatitis and nothing to
Absolutely.
do with infection.
Absolutely. An infection will be a redness that's sort of spreading away from the wound. Quite often it has finger-like projections and tracking and so on. And if you draw a line
So,
around that redness and it moves beyond that, then it is an infection.
so the mantra really is don't swab, but mark the edge of the wound and monitor it.
Yes. A lot of GPs these days are saying don't swab at all. I'll give you, if I think you
Yeah.
have a clinical infection, I will give you flucloxacillin, which is what NICE guidelines recommend. If it doesn't make any difference, then we'll consider swabbing. Now, if you do swab, you should always clean the wound first, because you've got to clean off that
Right.
surface colonisation, because it will be full of things like Pseudomonas and Staph aureus. You need to get down to the pathogen that's actually causing the problem. So if you think there's a clinical infection, you clean that off completely and then go as close to the surface of the wound as you can get. I mean, ideally it would be a biopsy, but we're not going to do that these days. The swab is
But
all you've got.
that's to a certain extent, that's the opposite of what I would logically advise, because it would be effectively like when you swab tonsillitis, for example. If you wipe all the bacteria off, you're not going to get anything after doing the swab, but of course it's a
Yeah.
completely different thing.
Yeah.
Talk to me about the biofilm. This is a word I hear a lot about, and I would love to hear your take on it.
Right, the biofilm, when you're actually looking through a microscope, it's very difficult to see because it's polysaccharide film. It's literally a clear film. And it builds around colonies of bacteria. And those colonies can be all sorts of bacteria. And they're building themselves little houses that they live within that you can't get to, either with dressings or with antibiotics. And it sticks to the surface of the wound. Now, you physically can look at it and you can see it with your eye. And I'll give you examples. If you go to your fridge and take out bacon that's been there a while and it's got pretty colours on it and it's slimy, that's a biofilm. If you feel your teeth in the morning and they're slimy first thing in the morning, I could see you doing it, that is a biofilm.
I just cleaned them, so they should be okay at the moment.
Absolutely.
The bacon, on the other hand, Christ.
Yes. And if you look down in a drain and you see that slime, that's a biofilm. And that comes onto wounds. So they say that 100% almost of wounds will have biofilms on them because there's more bacteria on everybody than there is on people on Earth. So you've got more bacteria on yourself than there are people on Earth. And if you get a wound, it sees it as a swimming pool and dives in. So all chronic wounds will have bacteria in them, and all chronic wounds will have biofilms. And those biofilms need to be cleaned away. And there are things coming on the market that will now do that. And we need to be aware of that. And we need to be aware of the biofilms and getting rid of them. But we should not be
And so
giving...
is the biofilm created by the bacteria to protect it? Is that
Yes.
so? It's
Yes,
a
it is.
natural process that the bacteria are doing.
Absolutely. It's like little bubbles. So these bacteria are inside these little bubbles. So when you give somebody antibiotics, it doesn't touch them. They're protected. And they laugh at you. You can hear these bacteria, actually, if you listen, you can hear them giggling, thinking, yeah, they think they've got me, but they haven't. And there
Yes,
are things that...
I'm very used to people laughing at me, and so
Yeah.
to hear that bacteria are doing it as well is disturbing. And because they create a bubble, is that why when you look at your bacon, it distorts the light? Is that why you're getting those colours?
Yes.
Is that the...
Yeah. And it's slimy. You
Got
get
you.
this slimy look to it and feel to it. If you touch it, it's slimy. It's a biofilm.
Yeah,
And if
yeah.
you wash it under hot water, you can actually restore the bacon and get rid of the biofilm. And, we've got to find ways to get rid of the biofilm from our wounds, and we can do that quite easily. But the bacteria
Right.
themselves are a pain, but they're not needing antibiotics. There are ways we can remove it without antibiotics. It's only when it gets into the host, and that's rare.
So extending that forward, what are the alternatives to antibiotics when there's no sign of clinical infection? So you sort of mentioned about removing it and some new products coming on the market. Could you just tell me a bit more about that?
Well, there are a lot of cleansing products. Some of them have little cuts in foam so that when you wipe it, you're pulling off all that biofilm. Others have soft claws that wipe away the biofilm. We also have antimicrobials, which are very much in use at the moment, such as silver, iodine, which is iodine cadexamers rather than a simple iodine. There is copper. I mean, copper is becoming very popular. PHMB, not so much these days, but PHMB is also an antimicrobial. There is a green product that actually attracts the bacteria and holds it within the product. So there's lots of things on the market that will help us, lots of cleansing products that will help us remove the biofilm. And it's very simple for us to do as nurses. We don't need antibiotics for that.
Well, one of the things I mentioned in the presentation was sort of patient demand or perception of demand for antibiotics. What are the sort of techniques, communication skills wise, that over the years you've found works without, so they go away feeling that they've not been deprived, and equally it maintains the clinician patient relationship. How do you break that sort of news?
Well, it's a case of people have become reliant on antibiotics and they expect their GP to prescribe it when they go to them. I've got a cold, so therefore I want antibiotics. And the only way you can overcome that with wounds is to explain to them that if they keep having antibiotics unnecessarily, they are going to end up with a resistant bacteria, which is going to be very hard to get rid of, and very few antibiotics that can touch it, and they can become then seriously ill. Whereas if they haven't got an infection and they don't need antibiotics, we can clean it with antibacterials, and very successfully.
Yes.
So, why would you need antibiotics? I mean,
I
maggots are
think
amazing for that.
it's yes. I mean, I think it's avoiding conflict, isn't it? And going back into that old sort of paternal approach to patients, and explaining exactly as you've said that there isn't a role for antibiotics, but I can help you by doing something else. My original trainer when I first started in general practice, if somebody came in and demanded antibiotics, he used to have a little box with like that you put your fishing things in. And he had lots of different colored pills. And he said, if you want antibiotics, I don't think you do, but you choose. And often they would pick the most colorful one, which was ibuprofen. So,
Yeah.
I mean, I'm joking, but I mean, genuinely, 25 years ago, he did that. But I think now we've got to educate the patients and bring them along and say that actually it would be harmful. And in the future, they may be giving themselves problems. But, ultimately we're going to try and negotiate the best way forward. And so why don't we try my method for a week or two, and then if it's still looking like that, then maybe we'll reconsider.
And we've also got to educate nurses and GPs about when to give antibiotics and not to give out just for red legs. To consider, is this red leg due to something else, not infection? In my 30 years experience, very rare to see a clinical infection, extremely rare.
And I think there are a number of different pressures, and I mentioned them in the talk earlier. But I think since I've been advising home wound care, I've learnt a lot about the fact that I probably overprescribed antibiotics, and I probably wouldn't now do the same. So I think it's just an education thing, and we're busy doing lots of other specialities and lots of other jobs, and so it is easier and quicker without thinking it through. But particularly the message about dermatitis, contact dermatitis with the dressing, looking at the biofilm, I think that's all really key. And so, as I say, I would certainly reduce my antibiotic prescribing as a result.
A comment on the top of that is that we can reduce antibiotics, but we've got to stop being scared of steroid ointment or cream, Because if we've got red legs and we put steroid cream 3 times, 3 applications, I recommend over 3 weeks, just 3 applications will get rid of that dermatitis. So we wouldn't need the antibiotic. No. We don't need lots of steroid ointment. Just those 3 applications will turn that patient around. And we've got to stop being frightened of how we use the Dermavate and those kind of steroid creams.
Absolutely, and once again, I've always been a bit anxious about applying steroid, but will be less so now, knowing the underlying pathology of what's going on in the wound. The World Health Authority have given quite a number of statements which have been quite scary to read, and it's in their top, antimicrobial resistance is in the top 10 of their threats to the world, and equally, that we're not far away from going to the pre-antibiotic era, in which case a lot of people will die of simple infections. With your lifetime of experience, what's your view of where we're going in the future?
I think we will go backwards to some of the treatments that we used to use before antibiotics. I am concerned that we're losing antibiotics slowly, simply because we've overused them. But I do think there will be something in the future. I mean, we are very clever about moving things on, and I'm pretty sure eventually the rainforest will come up with something. In fact, I think there is something in the wind at the moment about it, about something to replace antibiotics. But I do think we will go back to things like maggots. Maggots can sterilize a wound in 7 days. I mean, that's an amazing claim, isn't it? 7 days and you don't have one bacteria in the wound. Things like silver and iodine and those sort of things can clear the colonization to stop us getting clinical infections. Because all the time that we're keeping those bacteria out, we are removing the desperation of clinical infection. And I really do believe that we can do a lot more for wound care if we're a lot more careful about what we put on a wound. I find I do a lot of expert witness cases, huge amount, and I'm sometimes quite concerned about this. I've even seen tissue viability nurses saying, black oozing pressure ulcer, leave it open to the air. And if you're leaving it open to the air, you're leaving it open to the fact that bacteria can just use it as its swimming pool, and you can get pathogens in there. So let's consider using antimicrobials, but let's try and use them sensibly, because if we use antimicrobials willy-nilly, like silver, we shouldn't use silver more than 2 weeks, but we go on and on and on. I've had a patient who's had silver on for 9 months because the tissue viability nurse said to the district nurse, use silver. They continue to use it for 9 months. We are going to get resistance to those antimicrobials as well. So we have to be sensible about how we actually use them. But that's how we will stop bacteria getting into a wound, is by using appropriate dressings to actually remove that colonization.
Well, Sylvie, as always, it's been a huge education. I'm loving this journey into finding out about this sort of thing, and it certainly would change my practice. So once again, thanks for joining us. I'm sure we're going to get together soon with some different topics. And as I say, thanks again for joining us. And I hope that if you're listening to this, that you've enjoyed it. Do give us some feedback. And if there are topics that you'd like us to cover in the future, then please do. And we'll see you again soon.